Welcome all my viewers today once again on Heart Mitra. It's always a pleasure to connecting with our audiences live for these expert sessions. And as you are aware, Heart Mitra is created for all of you so that you keep on getting the right information related to cardiovascular health to keep yourself healthy. Not only we post information for you on a daily basis, but also we invite for you leading cardiologists from across the country who can talk to you directly and who can talk to you as a friend. I'm very glad to welcome Dr. Ramesh Babu from the city of Vijayawada today. So welcome to the program.
Thank you, Mr. Sanjeev.
So from our audiences, we keep on getting a lot of chats and they keep on putting in a lot of questions. And one of the things which people want to understand is that how do we, prevent the heart attacks and sudden cardiac deaths, which have off late, a lot of things are in news and prevalence is increasing. So we'll take in the questions today in this regard. But before we start taking the questions of audiences, let me formally introduce Dr. Ramesh Babu for all of you. He's a leading cardiologist from the city of Vijayawada. After completing his DM from prestigious All India Institute of Medical Sciences, Delhi, way back in 1988, he came back to his city, Vijayawada, and set up the first cardiac center with ICCU over there. He also was instrumental in setting up first advanced cath lab way back in 1996 in the whole of Coromandel region, contributing to the good cardiac health of the society. Now, since then, for last 35 years, he has treated more than 8 lakh patients and more than 1 lakh coronary angiographic procedures as well. Now, he has also pioneering work in the field of telemedicine, low-cost ECG in remote locations, and also introducing electronic medical records and smart ambulances. He has more than 20 participated. He has in international studies and a lot of awards to his credit. I must say that the list of his achievements is so long that he is an institution in himself, and he has hugely contributed to the overall healthcare ecosystem in the whole of Andhra Pradesh and in that region. It's our pleasure, sir, to host you today and welcome on the show. Let me now straight away invite you and hand over the stage to you to set the ball rolling, and you can set the context on today's topic, which is prevention of heart attack and sudden cardiac death, why it is so important, and why we need to be talking about this.
Yeah, thank you, Mr. Sanjeev. At the outset, I thank AstraZeneca team for taking up this Heart Mitra program to educate the general public. And today's topic is very close to my heart. That is the sudden cardiac death, which is a serious problem, public health problem across the globe. Almost 10% of all the deaths are sudden in onset, and majority of them are because of hidden coronary artery disease. Many times you must have seen people very active, even cine actors, very healthy, suddenly die. And despite the billions of dollars spent across the globe in the past 5-6 decades, we could achieve some improvement in improving the outcomes of acute heart attack and acute coronary syndromes, which we call as a secondary prevention. But the crux is many asymptomatic patients, when they present with either a heart attack or sudden cardiac death, unfortunately, 50% of the coronary artery disease presents in asymptomatic patients who look apparently healthy. So is it really the failure of the system to predict in a normal looking person that is going to have an attack or an arrest the next minute or next day or within a year or 5 years? The screening systems which we have been adopting, like risk factor stratification or ischemia stress testing, whatever, what all we have been following in a traditional manner, have failed to identify the right kind of people. So this is a problem now which is identified globally. Now sudden cardiac death is an important topic now which is being looked at in different perspective, and to identify the people who are prone for this, much ahead. You'll be surprised to know that many people think that sudden cardiac arrest or acute heart attack is a sudden event because if they have eaten something, they were stressful in the past 1 week. No. The seed for sudden cardiac death is there almost for 20, 25 years. And we have to pick up these people who are genetically predetermined, with genetic susceptibility, and we have to identify these people and give them sufficient caution, take aggressive measures to prevent these sudden events. At the same time, I must tell you that all these decades, most of the times the cardiologists, what they have been following the traditional methods of screening and the treatment methodology also, for example, statins, cholesterol lowering, all these things, either over treatment or under treatment. Almost it is to the tune of 50% over treated and under treated. Now, precision medicine is one important aspect, and that is going to take over and the future concept of handling the coronary artery disease and sudden cardiac death.
Yeah. No, thank you so very much, sir, for sharing the whole context to begin with. And we will take up and seek your guidance, all these things step by step. And to begin with, sir, for benefit of our common viewers, in the common parlance, we use these terms very regularly: heart attack or heart failure or sudden death. And many of us, probably don't even understand what's the difference between that. If you can help us, just define in a very simplified language that what's the difference between the three and how this should be approached.
Yeah. The heart attack is something like when the blood supply to a particular heart muscle territory is affected because the blood vessel supplying that particular muscle is affected by sudden occlusion. There is something like a plaque, cholesterol plaque, which gets ruptured. And once the cap ruptures, there is sudden attraction of the red blood cells, white blood cells, and platelets. And that causes say 30% or 50% blockade to 100% block. And then that suddenly results in heart muscle damage. That is called heart attack. So this heart attack sometimes causes electrical disturbance and can cause sudden cardiac arrest also. So they don't have time even to reach the hospital. So heart attack can cause either damage to the muscle, patients will have time to reach the hospital, or over a period of time they develop heart failure because enlargement and fall in the pumping function. And whereas sudden cardiac death is defined as the sudden circulatory collapse. So there is sudden absence of activity, pulseless, and that is within 1 hour of the onset of the symptoms, or a patient who is unwitnessed within the past 24 hours who was alive and for no definite obvious cause like accidents and all, when we don't identify in the last 24 hours who was seen alive, if it happens, that is also termed as sudden cardiac death. So there are several causes of sudden cardiac death, one of which is coronary artery disease, that is a heart attack, either minor, it can be very minor heart attack, it can cause sudden cardiac death because of the electrical heterogeneous dispersion and then electrical accident. And other causes, almost 70-80% of the sudden cardiac arrest or sudden cardiac death is because of the coronary artery disease. And the other 20%, there are many other things like congenital heart disease, the channelopathies, likewise the valvular heart disease, likewise, so there are other causes also. So now coming to the heart failure. Heart failure can be because of coronary artery disease, where there is blood vessel blockade to the blood vessels, heart muscle damage, gradually enlarges and results in heart failure, where pressure in the heart is increased. There is back pressure built up in the lungs because heart is a motor. When it is weak, it cannot pull blood or water from the lungs. There is congestion, and then there is congestion if there is a right heart failure in the whole body, in the lower limb swelling and all. So heart failure is left heart failure or right heart failure or both chambers fail. And coronary artery disease is one etiology for that, one cause. Other causes are without coronary artery disease, heart failure can occur with either simple muscle weakness due to either a viral infection or a bacterial infection or sometimes anti-cancer drugs which we give, right? So likewise, alcohol. So all these things can cause what we call as a heart failure with normal coronaries or incidental coronary artery disease. So this heart failure sometimes can be diastolic heart failure, where the pumping function is normal, but still there is a stiffness of the heart muscle. So this is called as diastolic heart failure. That is a different issue. So now you have to identify, and the most important part to handle the sudden cardiac death or acute heart attack is handling it, diagnosing it, so without missing the diagnosis and treating it in the golden hour. That is the prime. If you treat this in the first 1 hour, almost 80%, more than 80% of the deaths which are happening every minute, every day, whatever are happening across the globe are preventable deaths. Unfortunately, the systems, the knowledge, awareness for the patients, people, and also the treating physicians has to significantly improve to bring down the numbers and the mortality because of this sudden cardiac death.
Yeah. So thank you so very much for explaining this in detail in a simplified language. I'm sure this helps our viewers understand that these three things are different, uh, and don't get lost technically. In case you don't pick up a few things, please meet your cardiologist, and he would be able to help you diagnose and make you understand about this. So you talked about so many technologies now available, which are there, but still, why we are taking up this topic today is we see so much of prevalence increasing. Celebrities, who are apparently fit, going to the gym like Puneet Rajkumar, or we saw KRKs while singing. So they just, go down because of the sudden cardiac death. So why does it actually happen despite so much of advancement that we can't even take them to a hospital timely and we lose such situations?
Yeah, one thing I must tell you, whatever data we have, the scientific data, which is conducted in a reasonable scientific manner, you get from either US or European countries. Unfortunately, in India, the data is sparse, though some teams are trying to build up registries and trying to have a study on the Indian patients, how these patients behave. But we know for sure that Asian genes, genetic susceptibility is different and almost 3 to 6 times more than either US, Chinese, or Japanese people, the incidence of the prevalence of coronary artery disease. Now, why this is happening? It occurs almost a decade or a decade and a half earlier than Caucasians or people in the whites. So if they have an average of 60, 65, our people get average heart attack, average age is around 50, unfortunately. That is number one. Number two, though there are several factors like genetic susceptibility, number one, hypertension, diabetes, bad cholesterol, smoking, metabolic syndrome, obesity, these are considered risk factors, and all of us cardiologists have been focusing on these risk factors to screen the asymptomatic population who have hidden heart disease. This is called risk factor stratification scoring system. All of us have been believing in that. Framingham score system, or European score system, or Q-risk system, or pooled cohort equation. But none of these risk factor stratifications have been found to be very precise. Most of the times they overestimate or underestimate depending on the age, gender, other factors. Unfortunately, if you see my ICU or anybody's intensive care cardiac unit, we see almost 60 to 70%, that means 7 out of 10 patients who come to our ICU, they are so-called low-risk category patients. That means, in other words, if the person comes to my OPD one day prior, when I ask or go through the scoring systems, I say that this is a low-risk category, I reassure, and within 24 hours, the patient presents to the ICU with a heart attack. Why is this happening? So the traditional risk factor scoring systems have been proven to be not effective in an individual, especially these are not applicable for Indian patients, number one. Number two, The hidden heart disease, we were giving a lot of importance to the symptoms. Only when the patient was presenting with chest pain or a palpitation or shortness of breath, we were investigating. What investigations? I will come later. There also we went wrong. The traditional risk factor or ischemia stress testing also misled most of us cardiologists. Now, in the past 3-4 years, a lot of data is coming up, which I will share with you. So, risk factor score systems have misled. So-called pre-test likelihood of a disease have misled, and the downstream testing also pattern also is fallacious. Lot of lapses, lot of misguidance has happened, spending billions of dollars, confusing the people, physicians, population, and there is no proper information. I must tell you, the misinformation in cardiology amongst the public, among the physicians, even amongst the cardiologists, the debates and all, so much that in no other department, so much of debates, wastage of time, adapting to newer things which are really effective, wasting decades. Sometimes it takes decades to adapt really scientific, facts. So that which are useful. I'll come to that later. Why the delay in adoption of the guidelines and also framing the guidelines is also delayed. So this is now why it is happening. The hidden heart disease, which we were thinking more than 50% of the stenosis of the coronary arteries is responsible for heart attacks majority. But now we know less than 50% stenotic lesions are the cause for more than 60-70% of the heart attacks. This is another thing. Once you know the angiographic picture, even when 30% lesion was there, I still remember about a few years ago, I was telling 30 years is normal, everybody will have. Now we know that 30% lesion is very, very dangerous if it is a lipid block. So this ruptures and suddenly it causes the heart attack. These 30% people can run marathon. So Jim Fix was a marathon runner who was, running 20-25 miles without any problem, and suddenly he died one day while running, and his autopsy showed all 3 vessels blockade, 80-90%. So the exercise capacity has nothing to do with the existence of the hidden coronary artery disease. And now we don't believe that symptoms should be there to screen the cardiac patients, especially in India. This is also now, it will be surprising for you to know that people who are more than 45 years, who are aged more than 45 years, if you have them here and then do the CT coronary angiogram, 40% of them will have hidden heart disease. They'll be absolutely normal, going to the gym, they'll be running. So screening the asymptomatic population is very, very important, irrespective of the risk factors in Indian patients. This is what we have realized after doing 25,000 CT coronary angiograms, picking up a lot of patients. The other way also is right. Many patients, thousands, lakhs of patients are treated unnecessarily with lots of medication just because they have high blood pressure, or they have diabetes, or they have some lipid cholesterol. No, there is another genetic susceptibility gene which is not identified, and many people are over-treated just because they have this thing, and then we have realized that appropriate precision medicine is very, very important. So this is one aspect. Now we are talking about Puneet Rajkumar, a wonderful actor, wonderful personality who has conducted seminars in Jayadeva Institute about how to control and how to prevent sudden cardiac death in young patients. He conducted a seminar. Unfortunately, he succumbed to it because he had discomfort in the morning. He went to his private doctor and he was not, sent in a EMS, so emergency medical services with a defibrillator, shock-giving medicine, and all these things, equipment and all. And on the way, he died, unfortunately, by the time he reached the cardiologist. That means there is something like a golden hour. Whenever chest pain is there, either in the periphery or in the city, or educated people or uneducated people, many people feel that it is gastric trouble because most of the times, 90% of the times, heart attack occurs with burning sensation in the pit of the stomach or epigastrium. Because heart is in the center, it rotates to the left, and the neuronal connection, unfortunately, when there is a heart attack here in the muscle, the brain perceives that some burning sensation is there. That is how it is mistaken The word of gastric trouble kills many people. Many people give pantocid or injection, then they say if it doesn't get relieved in the night, you go tomorrow to the cardiologist. By the time many people are dead. Unfortunately, this is happening. This has happened with many people. And so the gold in our concept, the minute you diagnose or the minute the patient has got chest pain, unfortunately, chest pain again is misinterpreted. And 30% of the heart attacks are silent, or they are just very, very mild burning, and people just ignore. And misinterpretation of the ECG. ECG is normal. First ECG is normal in 45% of the people with heart attack in the first 1 hour. Unfortunately, misinterpretation of the ECG, misinterpretation of the chest pain, assuming that it is gastric trouble, then the denial of the patient and lack of knowledge, lack of access, lack of transport, odd hours, lot of things are resultant of this sudden cardiac death. Unfortunately, this actually, I get perturbed when a savable life and a person who is on whom the family is dependent, he had pain in the night, and somebody said, okay, you take pantocid, if it doesn't get relieved in the morning, you come. By the time he comes, he's in shock, he's in failure, whatever you do, he dies. So a lot of education has to go into the public, to the treating family physicians. Family physicians are responsible to save their patients, to identify the disease, hidden disease in their hearts, because they come to them with hypertension or fever or headache, and they miss the diagnosis for 10 years, 20 years. They have to find out a way, they have to identify the disease in its early stage, treat it, alert them so that they don't mistake it as a gastric trouble. So now the family physician's role, they are improving their knowledge. They are also trying to save the patients. They are trying to understand how to assess the hidden heart disease. And if you do this, we wouldn't have lost people like Puneet Rajkumar.
Yeah. So thank you so much. I think, and as I hear you more and more, we come to a conclusion that a lot of things needs to be corrected, and people need to be more aware about that. So let me ask you two, three very sharp questions and connect you straight away with our viewers and your patients who are listening to you. Now, you focused on early detection, reaching to the doctor timely. Let's talk to the common man today and the patient that what are those symptoms? Because you mentioned that a sudden cardiac death, it may happen, but the seed is sown many years ago, and there may be some things which can be picked up. So, are there any particular two, three, four symptoms which you would like to clearly share with the viewers today, that if they are facing those things, then don't wait for acute chest pain, and then they should immediately go to a cardiologist and get themselves screened.
Yeah, as I told you, first and foremost thing is to identify the hidden heart disease which doesn't have any symptoms. Okay, so that we'll discuss separately. What are the screening methods, what is the most cost effective method compared to the existing methods, what we have in traditional methods, which we have been inappropriately following for decades together. Now, a chest pain, as I said, in the person in the village, in the night, sometimes somebody gets more than 35 years or 40 years, he gets burning sensation in the pit of the stomach, in the center of the chest. It can be very light. There need not be any sweating. There need not be fall in the blood pressure. And most of the times it is in the center, but sometimes it can be only in the jaws. I've seen the patients going to the dentist, they extract the teeth because some teeth are loose, but then it is a cardiac pain which is radiated to the jaw. And then it can go to the shoulder, left shoulder or right shoulder or back. I've seen many patients going to the orthopedicians who have received physiotherapy for the hand, and after a day or two, they come with a massive heart attack and enlargement. Unfortunately, apart from being 30% of patients or heart attacks being silent, people who have attack also, the symptoms are so masquerading, like, it is like a burning or a gastric trouble, number one. Number two, in women, in elderly, they can have just some sort of palpitation or fatigue, some weakness, and or some sweating. And so many varied symptoms are there, and without chest pain, that is how many people also miss. So these are called angina equivalent. So when any patient, any person who did not have that feeling of palpitation or breathlessness or chest pain, which was not there and lasting more than 5, 10, 15 minutes, it should alert them. The ECG has to be taken, though in 45% we can miss, but at least the clinical picture and a sensible physician will understand that this is likely to be cardiac and ECG can be fallacious. Let me wait and check. Now we have something like a troponin. Troponin I or troponin T, a cardiac enzyme, after an hour or 2 hours or 3 hours, definitely it will go up. So at least when a 35, 40-year-old person goes to a doctor, he should hold the person for at least 3 to 4 hours till he decides or there is clear proof that it is not cardiac. Many times, many people, the misinterpretation of the chest pain in US, unfortunately, 4% of the litigation, 4% of the time chest pain is misinterpreted, it is missed, and then it is the largest litigation amount that is paid by the doctors even in US. So that is why the not to miss the diagnosis is very, very important, and high index of suspicion, being patient, not being dogmatic, not giving advices by telephone. When his patient phones, I am having burning, then don't tell you gave Dizine. If it doesn't respond, then come here. No, absolutely no advice via telephone for chest pain patients. This is mandatory. American Heart Association says, no, don't talk about any remedies over phone.
Okay. So I think that's a pretty sharp answer. Look out for these symptoms. If you have these, don't be in a sense of denial. Time is life here. You should immediately go and reach out to your cardiologist. You emphasize, sir, on the importance of the golden hour and the first 60 minutes. Now, there can be many situations, sir, where let's say a patient is in a big city where a big hospital is nearby, or there can be a situation where he's a little far away. So how should the first hour what should be done exactly step by step in that first hour? Is there any role which family physicians can specifically play at that time to save life and by the time patient reaches the cardiologist?
Yeah, see, no, even largest experienced cardiologist can make a diagnosis of heart attack just by seeing, listening without an electrocardiogram. Okay, this is fundamental thing. And to have an ECG in a periphery or in tribal areas in a country like India, and to have an access to have a person who can interpret it properly is a very, very difficult thing. But fortunately, I must tell you, the National Digital Health Mission, now the Niti Aayog, which has come up in the past 7-8 years, is taking a lot of initiatives to see that every patient, every person is registered, and the telemedicine role is being increasingly recognized. In fact, we started telemedicine almost 11, 12 years ago when people were not aware what it is. Now telemedicine has helped during COVID time, So now we donated ECGs in the periphery sometime in year 2000, to a lot of villages and mandals where we could get through fax. At the time, there was no mobile. We used to get fax ECGs from the family doctor, who used to tell them over telephone, this is heart attack, this is not, so this is what you have to give. So the availability now with the communication systems, you have to utilize it. The simple WhatsApp. Now the family doctor, or even diagnostic ECG centers, they can take an ECG, they can send it to a physician who can properly interpret and then advise. That is number one. Number two, they should have emergency medical services, ambulances available with proper technical person who can give a shot or on the way. And then now with the National Digital Mission, it is connecting the people to the doctors, to the nearest hospitals, and apart from, of course, the Ayushman Bharat and all these things. Now, in India, I must tell you, there have been phenomenal change in the past decade with regard to management of health emergencies, especially. And I'm sure in the next few years, this is going to grassroots, and India definitely will be much, much better off in providing healthcare to the people downtrodden and who are in the peripheries, in the tribal areas and inaccessible areas, through just by the communication system, establishing networking, bringing the people in line who can deliver, who can provide answers to this and interpret.
Yeah. And we must appreciate you, sir, here. As I was reading through that, you have enabled a fleet of ambulances, which are smart ambulances with 5G tech enabled. So I think these things go a long way, and that's the best use of technology to save life. This we talked about, sir, the symptomatic patients. Now let's come on to the asymptomatic patients, who may have only risk factors but don't have apparent, large chest pains or the other symptoms which you mentioned. What should be the prevention strategy for them? What is the screening protocol, for those patients? Is there any age from which screening should start? What should be the frequency of screening? We have heard about a lot of risk scores like calcium risk scores. So can you elaborate on this and help our viewers?
Yeah, as I have been talking, the symptoms and then the screening. Uh, as I told you, because of whatever the resource availability and optimal utilization, we were going through a traditional risk factor and ischemia stress testing, and before trying to identify whether the patient has got disease. But though data is known for over 20 years, that patients, 50% of the times, patients do not have any symptoms and they come suddenly with a heart attack or they die. But still, there have been a lot of debates, the guidelines and everything says asymptomatic patients need not be evaluated for coronary artery disease. That is wrong. Now it is proven to be wrong because we have data now, something like a escapist registry. We have Miami registry data wherein you are now sure that symptoms do not have anything with regard to the presence of a heart disease, and more than 40-45% of the patients have heart disease, and maybe 3 to 5% of them have very critical disease also. Now, so identifying the disease, there is no way your ECG will be normal, your exercise treadmill or nuclear stress test or dobutamine MRI, everything will be negative when the disease is less than 50%, so-called significant or insignificant. So the only way to identify asymptomatic or subclinical atherosclerosis, what we call either advanced or early subclinical atherosclerosis, you have to identify because there is something like a genetic susceptibility gene. As you know, as cardiologists, it was a surprise for us when we conduct angiogram in a patient of 70-year-old who has hypertension, diabetes, smoker, family history, and to our surprise, his coronaries are normal. On the other hand, a 30-year-old female who comes with some atypical chest pain, okay, repeatedly she comes, and we think that she will not have anything, but we go and do the angiogram, we find 3 vessel disease. So there is something like a susceptibility gene. The details, the prevalence, how it is there in India, still we do not have complete data. Even in US, it is a multifactorial, 200 genes, 300 genes are implicated. But still, we do not know which patient is really prone. So in India, what I do is, for every patient who has got a family history of heart disease, number one, if he is more than 30 years, or who has got metabolic disease, or at least one risk factor, hypertension, diabetes, bad cholesterol, LDL more than 160, I do a CT coronary angiogram. And because calcium score will mislead me sometimes, though calcium score is a lower level, at least for mass screening it will be helpful. So where is calcium coming from? See, I must tell you, there have been a lot of debates, misinformation amongst even our own people that, okay, calcium score, you are comparing with it, with a ischemia stress testing, you are comparing it with a risk factor scoring, where you are guessing a heart disease by doing these tests, so-called treadmill, nuclear medicine tests and all, and risk factor stratification. Whereas in calcium means already there is a disease. So you are closing your eyes and guessing that coronary artery disease is there by following, adopting these and kind of trying to compare it with the calcium score, which is absolutely not true. Calcium score is nothing. You are peeping into the coronary arteries and the cholesterol which is there over a period of time, part of it will become calcium. So when calcium is there, even one calcium is important compared to 0 calcium. One calcium means the person is already susceptible. Already cholesterol blocking has started. You have to address his LDL cholesterol. You have to go for aggressive medical measures, including weight control, BP control, diabetes control, and all. So, asymptomatic patient treatment is very, very important, because if the patient has got chest pain, if you educate the people, if you educate the doctors about the ACLS, BLS, golden hour, you're having an ECG transmission, having an EMS ambulance, then it is easy to save the person if the patient has got some symptoms, provided people are properly educated. But on the other hand, it's extremely difficult, because many people come to me, the spouse comes, a heart attack, a 35-year-old guy gets admitted into the ICU, then I say it is a heart attack, the spouse doesn't believe. She says, day before, the guy went to a cardiologist, he did his ECG, echocardiogram, a treadmill test, ECG, everything was normal. You are saying heart attack, how can it happen? So this is the unfortunate thing. So symptoms do not have anything, and the traditional methods which all the cardiologists, all of us have been following, are wrong. We have to come out of that shell, and we have to identify the disease appropriately. And in India, since we don't have enough data and we are seeing so many sudden cardiac deaths, every other day we do see somebody in the city has died. So it's an emergency situation. In fact, like COVID, the heart attack in emergency, people were attributing it to COVID. No, this sudden cardiac death is there even much before COVID. It has got. And then identification, the population is increasing. Now you are able to have more communication. So you are able to hear more deaths. So this is what's happening.
Okay. So here, I think we get the emphasis from here that only the conventional ways of screening may not be the best ways to detect early heart attack, and therefore it's important that you get your risk score done, stratification done. We also hear about, sir, the advanced things now, like CT angiogram, coronary angiogram, or cath angiogram. Are they good tools to detect heart failure or heart attack, and which one of them is advised by you or better?
Yeah. So now, recently, the American Cardiology, the Heart Association, there is an article saying that cath angiogram doesn't add anything more than CT coronary angiogram. So if you talk about invasive cath angiogram, which we were considering as gold standard, now it is no more gold standard, because the complication rate with CT angiogram is much less compared to cath angiogram, and you get equal data, if not more data, because cath angiogram is a luminogram where you may see normal coronaries if there is a diffuse atherosclerotic plaque, whereas you will see the plaque, the calcium score, and in the bifurcation in the ostia, better delineation with the CT coronary angiogram. Now, even if the patient has got stable angina pectoris, classical angina, or non-anginal or atypical chest pain, or when the patient has got risk factors, then go for CT angiogram rather than the treadmill test. As I was telling, the traditional test, what I was doing, a treadmill test to screen the patient. If it is positive, okay, you are sending the patient to angiogram. We are wrong, because the predictive value of treadmill test is very low, false positive, false negative. We were seeing many normal angiograms with the positive treadmills and abnormal angiograms with the negative treadmill. So now the CT coronary angiogram is superior in a sense. Cath angiogram we do. When do we do? When we find something in the CT angiogram, 60-70%, or critical disease, where you want to do the stenting, or when there is a doubtful diagnosis of the severity, then you do cath angiogram. Apart from that, you have to do something like a fractional flow result or instantaneous flow result or intracoronary imaging to identify the significance of the atherosclerotic plaque. Then only you will know what to do. So what all we have been dealing in the coronary angiogram interpretation, now it is known that it is overread or underread in 50%. So coronary angiogram, what we were interpreting as a significant was not significant. What we were thinking it is insignificant, now with the FFR and intracoronary imaging, we know that it is significant. So the treatment concept, the pathophysiological concept, the diagnosis, therapy now have changed, have seen a sea change. Since 2021, when American Heart Association, European Heart Association, everybody changed the guidelines. Now they know how to handle a stable chest pain, how to handle acute chest pain, and then how you utilize from the armamentarium of investigations, avoid inappropriate usage. That means choose wisely. Value-based healthcare. Now the American healthcare, all these the systems, they are talking about the insurance systems. They are talking about value-based healthcare. They won't pay if it is normal. They say that 80% of the stress tests are inappropriate. So don't do unnecessarily. You do these stress tests downstream when you find 70% stenosis, when you want to identify as is causing the symptoms. You do the stress test at the time, not before. So this is what is the change which has happened now.
Okay. So I think that's very, very important point which Dr. Ramesh Babu has mentioned. So if you have risk factors, you go to your cardiologist and you are advised a CT angiogram to understand the risk. So please don't be in a sense of denial. Some of these screenings can be very, very useful in detecting early and saving your life as well. So let's move forward. Now, in the overall scheme of things, if we see, we are more prosperous, we eat more, we have all kinds of foods, we have more number of cars. So therefore, a lot of changes in recent decades have happened in our dietary patterns or in our activity, lifestyle related things. Are they also contributing towards this, increased cardiac risk? Do you have any advice on this? That what are the best ways to manage on these two things?
Yeah. So there is something like essential 8 for cardiovascular health. One is diet, weight, physical activity, quit smoking, and the others are hypertension, diabetes, then controlling the cholesterol, and then the obesity. So once you have the sleep pattern, the other is the most important, 8th is the sleep. So a good sleep, a pollution-less, a healthy atmosphere, these are also important to maintain, to keep good cardiovascular health. Now they are giving scoring system, less than 50, 50 to 75, more than 75. Likewise, if you want to maintain good cardiovascular health, a good diet, good physical activity. So burning, you're talking about 10,000 steps a day, or at least 5 days out of 6, 7 days, at least vigorous exercise for about at least 30 minutes to 45 minutes, brisk walk or doing something, or swimming or whatever. So physical activity. Then the diet, coming to the diet, there have been a lot of debate over diet, keto diet, this diet, that diet and all. But we know that the polyunsaturated fatty acids, which are there in the nuts, it be, groundnuts or cashew nuts or any nut, and also the fresh fruits and the vegetables. These have positive impact on cardiovascular health. So the diet part, avoid fried foods, deep fried foods, even if a deep fried fish, we have to avoid. So have healthy dietary patterns, maintain ideal body weight. In India, ideal body weight, BMI is 23, not 25, right? So ideal body weight, maintain the blood pressure. There has been a lot of debate. What is the blood pressure? Since, 30 years, we were discussing 140 is okay, 150 is okay for a 60-year-old person. No. Now we know that even for a 60-year or a 70-year person, blood pressure of 120, 125, if it can be tolerated, that is better to prevent cardiovascular events. The more the pressure, the more it hits with the higher pressure, the shoulders of the coronary plaques, it causes a rupture. So the old belief that age plus, your blood pressure 100, let us say 60. So if it is 220, if for a 60-year-old, 160 plus 60, that is not normal. So your the heart rate, the blood pressure now 150 or 100 plus 60. People used to say, if the blood pressure is 160 in a 60-year-old man, we used to think it was normal. No. Now you know that 120 to 130 blood pressure maintenance. LDL cholesterol, there is a lot of debate on cholesterol, debate on statins. Our own doctors are worried to take statins because it causes muscle pain, it has side effects, it can cause diabetes. No, when there is an indication, you have to take statin. Statin will reduce the LDL cholesterol, and the level of the LDL cholesterol, there used to be debate 115, 100, 70. Now you know what is ultra low LDL cholesterol, where if there is severe diffuse disease of the coronary arteries, even maintaining 20, 30 milligrams of LDL cholesterol is good to prevent the events. It causes shrinkage of the cholesterol plaques. So a lot of change in concepts in terms of risk factor, the diet, the sleep, the physical activity, everything has come up in the recent past.
Yeah, I think our viewers are today getting an absolutely latest updates on all these concepts from you, Dr. Ramesh, and I must thank you on this. And these eight cardinal rules, I think, are important as he explained. So remember them. In case you are missing on one or two things, this program is going to stay here. Just rewind back, listen to him again, and these are very very vital things for your good cardiac health. So now let's take an, since we're also running out of time, we'll take a couple of questions to, conclude the program. Now, if someone has, got an event, unfortunately, despite all the good work suggested by his doctors, and he's coming to you and now he has to undergo a procedure. There are a lot of options at times given to the patients that whether a stenting has to be done or, a cardiac bypass surgery has to be done, and at times there is a sense of confusion among the patients because they don't have enough knowledge. So we just wanted to help you understand that how these things are decided. Does a patient have a role in deciding this, or it is an absolutely a medical decision on what should be done?
Yeah, very important, pertinent question, which is confusing and also a lot of debated questions, for the past 30 years, 40 years. What to do when a patient has got multi-vessel disease? Whether medical management or a multiple stents or bypass surgery. Out of these three, the consensus, we have seen people being operated for a single vessel disease, bypass surgery, about 40, 50 years ago. That was right at the time. But now we know, unless there is critical disease in the left main or in the very proximal disease of the major vessels, intervention will not do any more good than aggressive medical management, dietary control, physical activity. And now aggressive control of blood pressure, cholesterol, if necessary, with high doses of statins or evolocumab or some other drugs are there, which by injectables, which can bring down the LDL cholesterol, and borderline lesions, how to handle. There is a lot of confusion, but now we know that medical management is very good in a good number of patients. But when you talk about multi-vessel disease and left main disease, bypass surgery is supposed to be better than multiple stents in majority of the situations, unless the patient is in a bad surgical risk. Patients has got serious comorbid conditions where the surgical risk will be definitely more. But whatever it is, we decide that most of the confusion in the past 20 years has been eyeballing. We were interpreting coronary angiogram, okay, 2 vessel, 3 vessel, significant disease, by which we meant 50% diameter stenosis. Now we know that we went wrong many times. And that is the cause for debate amongst the cardiologists, among the surgeons, and a lot of things, a lot of debates happening. Now, the issue is when you have critical disease in the critical areas, yes, some intervention will help, especially in young patients when we cannot control with the medication. The symptomatology and the longevity also can be impacted if good surgical result is given. Now, coming back, if there is a single vessel disease or if there is an acute heart attack, majority of the times we try to open with the stent, not go for bypass surgery. But in acute heart attack, if there are multiple blocks where the stents will not help or one stent will not help, multiple 95%, 99% block, then we send the patient even to the bypass surgery with intra-aortic balloon pump support or whatever, Impella or ECMO, we send the patients for bypass surgery. But majority of the acute heart attack patients, stents are the preferred mode, or if stents are not available, or within the first 1 hour, what we call as pharmaco-invasive therapy. We give injection like tenecteplase in the periphery. We shift the patient to cath lab where it can be done, angiogram can be done, and necessary treatment can be given. So stents are definitely useful, but at one point of time, they were overused. Now we know where to use, where not to use, and how to get the best results by intracoronary imaging, OCT or IVUS. We see that the stent is approximated well to the vessel wall, it expands well, and so that the long-term results will be very good. And compared to the earlier era, 10 years, 15 years ago, the stent results are extremely good. Now the thrombosis is less, the long-term patency is very good. So in certain situations, stents are definitely useful.
Okay. So I think that's again explained, and there is no, it's not a gut feeling that how or what will be done in such a patient. It's a very, very intensely thought out medical decision by your doctors that what is the best treatment option for you in such a situation. So trust and go by your doctor's advice and get it done. So one final question I'll take, and that's very important that once you have done the procedure of a patient and you have sent him back, so there are some important medicines to be taken like blood thinners and all. How important they are for the stability of this procedure and the longevity of the stent which you put, and because we see a lot of such issues that someone goes back after cardiac stenting or he undergoes a minor surgery, maybe a eye surgery or knee surgery, and then certain medicines are stopped. So, what's the your guidance over there in such situations?
Yeah. So I would like to tell you that the blood thinners are used to prevent thrombosis in an atherosclerotic plaque because many times the plaque ruptures, small thrombus forms, it gets dissolved. Likewise, so you prevent this thrombus formation through blood thinners, antiplatelet drugs, either clopidogrel or ticagrelor or proxygrel, whatever, and then aspirin in some cases. So now these blood thinners are given. There are two types. Another is acetrom or esinoquinone, where after valve replacement we give. So frequently we encounter this problem. Patient comes for eye surgery, cataract surgery. He wants to stop antiplatelet drugs. He wants to stop acetrom when the valve is there. And many times we see patients stop without informing us. They stop for 5 days, 7 days. They undergo the surgery. They come back either with a valve getting stuck or a stent getting thrombosed. Many times we do see. So now, though the guidelines are not very clear, we have to see that the minimum gap, minimum period of stoppage of these drugs is there. And as soon as the procedure is done, at the earliest, depending on the thrombotic tendency and hemorrhagic tendency, you have to start within 24 to 48 hours. The bridging therapy with low market heparin or cannula or whatever, it is still, it depends on the situation. And in certain specific surgeries like spinal cord surgeries, prostate surgery, the ocular, intraocular surgery, which is surgery. So you have the hemorrhage is more, so you have to definitely stop. Again, it depends. After stenting, maybe after 6 months or 1 year, the chances of getting a stent occlusion, even when you stop, are less. But even then, we have seen after 3 to 4 years after stenting, once they stop the blood thinners, suddenly the stent gets clogged. And the other thing is, this blood thinner, at least one blood thinner has to be taken for life. The statin, once the coronary artery disease is there, it has to be taken for life. These two drugs are very important. Blood pressure, it has to be between 120 to 130 for any patient with coronary artery disease. So for cataract surgery, for dental surgery, many patients, many doctors do not stop these drugs, only for root canal therapy or vitreous intraocular surgery or complex areas where bleeding, if it occurs, difficult to control. So these are the areas where you need to stop. Otherwise, for simple dental extraction, you shouldn't stop the medication. Likewise, the acetrom which you give for valve replacement, you should bridge it with definitely heparin and then start it as early as possible.
Well, thank you for clarifying on this, because these are some of the things which are very, very important to keep you in good shape after you have undergone a procedure. Well, I must thank you, Dr. Ramesh Babu, today. You have covered this subject so very well, right from the prevention to what the importance of golden hour to what the patient should be doing, and then how the whole screening mechanism has to be done. I think the messages which you get today from Dr. Ramesh Babu are extremely important for not only people who are undergoing a cardiac disease or but also for those who have family history of cardiac disease or who have the risk factors. And it is extremely important that we understand some of the points mentioned by Dr. Ramesh Babu, and safeguard ourselves early itself in the life cycle of these diseases. Before I conclude and thank all our viewers, I must thank Dr. Ramesh Babu, and once again, sir, I'll give it back to you that just in case you like to summarize, this some of the important things here, or in case there is anything important which we have still missed and you want to emphasize, it's all yours to conclude the program.
Yeah, to all the viewers and all the family physicians, it is you, your important family member or head of the family, it is your duty to protect yourself. Try to acquire basic understanding. Don't get panicky when there is something with regard to health, especially chest pain. Be mentally prepared where to go, how to arrange funds or insurance or Arabishri, Ayushman Bharat or whatever facility. You need to be prepared well for a sudden heart attack. Don't get panicky because it is imminent in Indian patients. You never know. Be very, very cautious and be cognizant of the fact. Number one, the family physicians, it is you, family physicians, whether in the village or MBBS or whatever other departmental consultants, every patient more than 35, 40 years in India, Asia, may be harboring a gene which can result in silent coronary artery disease. Don't get surprised if the person comes to you after a week who was healthy but it comes with heart attack. The heart attack has not occurred because he has eaten something or he was stressful. No, he has disease for 10, 20 years prior to this event. So we have missed. So don't miss your own, because you are the family doctor. You should know how not to miss, how to screen the patient properly. Forget about the risk factors, forget about the treadmill test, ECG, echo, cholesterol, normal. No, normal cholesterol is there in many heart attack patients. Okay, almost 70% will have normal. So all the old concepts are gone. In the past 3 to 4 years, a lot of knowledge is poured in. Please update your knowledge and save your patients. This is important. And for all the healthy young people, essential 8, as I mentioned. So be very, very, have knowledge about these factors and control your diet, weight, exercise, physical, quit smoking, and learn some basic skills like BLS, basic life support, bystander. In India, unfortunately, only 10%, less than, not even 10%. Even in US, 10-20% have. The target is 60% of the population should be having at least BLS, basic knowledge, bystander, CPR. So this is another important thing. So people should be aware. And of course, the Niti Aayog and this thing, the National Digital Health Mission is taking extreme steps to improve the health of the community and the Indians. So I'm very glad about it, and all of us should become part of it, and to see that we also contribute in the public health.
Well, thank you so very much. And I must thank all our viewers who joined us live today or who will be watching this program later on as well. If you have anyone in your friend circle or family who have the risk factors for cardiac disease or already have an existing cardiac disease, you can simply share the link of this program with them. And this discussion and the points mentioned by Dr. Ramesh Babu can be very, very useful and life saving for them. So with this, we thank everyone. And Dr. Ramesh, we thank you so much for being so kind. You took out your 1 hour today from your busy schedule and have been answering some of the very, very basic questions which I asked you for the benefit of my viewers. Thank you so very much and good night, sir. Bye-bye and bye, everyone.
Yeah, thank you, AstraZeneca. Thank you, Mr. Sanjeev. Thank you.